concerned. I had a long presentation for Dr. Awf, but because of this sort of like technical problem, I'm going to be very short and say that it is my honor to present my mentor, Prophet Dr. Awf Quapa. For a lot of you, maybe has not been there in the 70s and in the 80s when Dr. Awf was student and resident, but I was there. So he was our idol. Awf was never accept to be number two in anything. So he is one of the few people who graduate with very good. I know now if we give a student very good, he would not be very happy, but at that time to graduate with very good is an outstanding achievement. I had the other chance to see him as a houseman for him, and I learned from him a lot. It was a fantastic experience for me to work with Dr. Awf, who was at that time sort of, we know he's going to be the plastic surgeon. I was more even fortunate to see him again in England and really sort of like meet him regularly. And when I gave my lecture how to give a lecture, how to write a paper last time, I told you the first paper who mentored me to write the first paper to reach my 600 or 700 papers. So I owe him a lot. He is, I don't want to tell you, but Dr. Awf is an artist, he's a human, he's a doctor, he's an excellent plastic surgeon. I can say a lot about him, but I want to leave the stage for him and thank him for accepting with his sort of busy schedule to give these talks. And he هو ابن الموصل وهو ابن المؤسسين. He is one of the sort of the founder of this مجموعة دعم الموصل. I remember I was in his house when we started this. So Dr. Awf, the floor is yours. Thank you very much for accepting to give this presentation.
شكرا قتيبة, شكرا Dr. Osama. Assalamu alaikum. I think I know that we have lost a bit of time, and I don't know whether we still have an hour. I could reduce my talk if you want to, but I better make a prompt to start. So I'm just going to share a screen with you. And thanks again for the invitation. Do you see my screen? Are we?
Yeah, it's clear.
You see the screen, okay.
أستاذ عوف خذ راحتك لأن هاي فرصة لنا كلتنا
Okay. Well, I'll try to limit the talk as a plan for 1 hour.
ونعتذر مرة ثانية على التأخير اللي حصل.
No problem at all. It's my pleasure. Okay, so we're going to talking about some basic principles in rhinoplasty. It's a huge subject, which is very difficult to cover in an hour, but we're talking about the basics. And the basics start with anatomy. The surface anatomy of the nose, there's so many terms that any rhinoplasty surgeon should be familiar with. Things which are not commonly said, radix, columella, and so on. It's difficult to learn anatomy from the books. If we to do rhinoplasty properly, we need to go to the dissecting room and do the cadaver. So the nose is made of the nasal bones, and the nasal bones, you don't realize how thin they are. They are paper thin, where you need to remove a bump or a hump. Higher up and on the sides, it becomes much thicker. Please tell me if there is any problem with the, you seeing all the pictures as they are moving?
There is no picture that's here. There is no picture.
There's no picture, did you say?
Yeah.
Okay. We can send thanks for the invitation.
Okay, let me escape from the
Just the first slide. Yeah, it's now it's okay.
Well, I better do it this way. Okay, so as I said, we learn anatomy from books, but for rhinoplasty, you need to visit the dissecting room before you start doing this procedure seriously. The nasal bones are very thin. They are paper thin. They become thicker as we move superiorly and to the sides. The nasal bones are frequently asymmetric in length and in shape. This is a diagram that I show to my patients when I talk to them and explain the features that they want changing. I tell them that the top third of the nose is made of bone, the middle third of cartilage, the tip is made of flesh, skin, and cartilage. The structure of the middle third is two triangular bones. They are hidden at the top by the bones and at the bottom by the other cartilages. It's referred to the middle third as the midvault of the nose. That cartilage is firmly attached to the bone and it should be left attached. If it is detached, you get a problem with rhinoplasty. You cannot move the middle third inwards. So these are basic anatomical facts that are required to understand the procedure and the technique. If we look at a cross-section of the nose in this area, we find that the cartilages do not meet directly. They curve, they have a shoulder to meet the partition of the nose. And in this way, there is a space for the air to flow. This is the inner valve in here. If we remove some of these cartilages, the top cartilage and the bone, we end removing the roof of the bridge of the nose. And this may look good initially, but if we do not restore the structure, the cartilage, the lateral and result in a deformity. That is why it needs to be reconstructed. We will talk about this in a second. While the mid-third of the nose, the cartilages are relatively simple and flat, the cartilages that forms the tip of the nose are very complex and they vary a great deal from one individual to another. We call them the lower lateral cartilages. I tell my patients that they are like your thumbprints. There are no two patients who have the same configuration of cartilages. They vary in size, in width, in shape, in strength. And that is why tips of the nose are very variable. These two patients, I thought that the cartilages were the same. When I exposed them, one looked like this, the other looked like that. So it's not uncommon thing that we see asymmetric cartilages in here. If we consider that this part, which is the lateral cross, 1, 2, and the medial crura, they form a tripod that supports the nose. And understanding this principle is very important because if we shorten this, the tip dips down. If number 1 and 2 are very long, the tip projects forward, and so on. So by modifying these, we can achieve different shapes. There are points within this structure that defines the tip of the nose and makes it so special and so different in different individuals and in different races. The partition of the nose, I'm covering the anatomy of the nose in 5 minutes. So forgive me if I skip quite a number of things. The septum is very important in rhinoplasty, in modern rhinoplasty. There is hardly a rhinoplasty procedure that I do not expose the septum, either to take a graft or straighten it or to modify it. If we look at a section in this area, so that is the dorsum of the nose. This is the cartilaginous septum. This is the bony septum. This is the bone joining the cartilages here. This area is called the keystone area because if it is disturbed during rhinoplasty, the nose will collapse. Of course, the septum is made of cartilage. That is a cadaver specimen and bone. And it's a fantastic source of cartilage graft that we can use for our reconstructions. The partition of the nose, to expose it, you need to lift the mucoperichondrium, and it's not an easy procedure. If you don't get in the correct plane, there is going to be quite a bit of bleeding. There are so many deviations and classifications of the septum that I don't want to bother you with, but approximately 40% of patients presenting for rhinoplasty will have a significant deviation of the septum. One interesting fact is that if the deviation of the septum happened early in life, the patient does not complain of breathing difficulty. But the impact of the deviation is profound on the shape of the nose. That is another thing that I show to my patients. I tell them the nose is like a tent or a pyramid. It's supported by a strut or a partition in here. If this deviates, the whole structure becomes distorted. One other thing about the anatomy is the skin. So the skin in Europeans, Caucasians, is usually thin, and you could see the structure through it. The skin can be thick, particularly in the tip area, and this skin is so thick that this is not a rhinoplasty patient at all. So if we look at the results of a rhinoplasty in these patients, we see that we achieved quite a sculpted look in this girl. The tip still looks undefined. This patient did not get rhinoplasty, got the skin treated by shaving and laser. One thing about noses in the Middle East is that the cartilages, although the nose looks large, the cartilages are weak and the skin is relatively thick. Still with the anatomy, the muscles of the nose are, we call them the smash of the nose. There is a depressor muscle that moves the tip of the nose. And there was at some stage in individuals, rhinoplasty surgeons who removed this muscle. That is a practice that is frowned upon now because it can result in disturbance of the function of the upper lip. The vascular anatomy of the nose is also complex. The nose is very vascular, and that is, of course, relevant when we do our rhinoplasty. If there is significant bleeding, you cannot do the procedure properly. The lesson from the above is that if you really want to seriously do rhinoplasty, you need to attend a cadaver dissection course, which is devoted or meant for rhinoplasty. The physiology in 1 minute, it is very important to tell your patients that the function is more important than the form, and that rhinoplasty should not cause functional problems, namely difficulty breathing. Again, that is a picture that I show my patients just to remind them that there is complex anatomy underneath the surface and that we have to look after this. I tell them about the external valve, and that is you ask them to take a deeper breath of it is the valve weak and may need to be, I tell them about the internal valve, which is at the junction of the upper and the lower lateral cartilages. You can see the edge of it in here. Okay, so that's the physiology very quickly. Now, if you want, again, to do rhinoplasty properly, please spend 3 to 6 months with an ENT colleague. That is one thing I regret not doing as a resident. I rely sometimes on our colleagues here who help breathing problems before committing a patient to rhinoplasty, not as a matter of routine, but if there is any indication for that. Another thing we need to know, some basics about rhinoplasty are the aesthetics, the artistic side of rhinoplasty. And what is a nice nose and what is a not so nice nose? I mean, these two ladies have, both of them are very pretty, but they have different noses, and both noses are very, very nice. So there are a lot of racial variations, and it is a big mistake that somebody who is an Iraqi or an Egyptian asks you to give them a nose that is European. It does not fit the face. It does not look right. So there are some guidelines that tell us about rhinoplasty, and most of these guidelines, I'm afraid, are to do with the Caucasian European noses. So I'll give you some examples. If we draw a line in the middle, the two sides will be symmetrical. If we draw 2 lines on each side of the nose, that width should be equal to the width of the eye. 3 lines divide the face into thirds, equal forehead, mid-face, the length of the nose, and the lips and the chin. The distance between these 2 lines should be equal to the length from here to here. That's the projection of the nose. A line is drawn from the nasofrontal angle to the tip of the nose. The bridge line should be a little behind, and so on. There's so many of them, and they are available in. So these are some lines. We're talking about curves. If we draw a line from the eyebrow towards the tip, it should be nice and uninterrupted. Angles. The angle between the lip and the nose in a female, again, remember, we're talking about Caucasians and Europeans. It's 95 to 100. In a man, it's 90. If it is less than that, the tip is a droopy. Points. The shape of the cartilages, the alar cartilages, define 4 points, which gives us quite a sculpted and nice look. And sometimes we try to reproduce this by using graphs. The chin should never be missed when we talk about, when we assess a patient with rhinoplasty. The chin should fall close to a line dropped vertically from the nasofrontal angle to the horizontal line of the face, the Frankfurt plane. Okay. There are Western noses, African, Middle Eastern, Asian, Oriental. They are all nice. You know who this person is who decided to have a rhinoplasty. I think she had it done in America quite some time ago when reduction rhinoplasty was the vogue. And I think her nose collapsed later on, judging by some of the images that I see of her. Okay. Some very basic information that we mentioned. How do we conduct a consultation with a patient requesting rhinoplasty? This is much more important and significant than the operation itself. Remember, you can produce a nose that is not fantastic, but the patient will be happy if you have assessed her or him carefully, and you can produce the most beautiful nose in a patient with very high expectations, who will not be happy. So the consultation is important. I'm not going to go through the general history, blood pressure, clotting problems, whatever. Specific history, ask about history, previous surgery. Currently, we have big problem in the UK with fillers. Patients are going and having non-surgical rhinoplasties, and they come and see you later on and say, could you reshape my nose? They don't tell you that some of the features have been hidden with the fillers, or the fillers are still there. If there are nasal symptoms, if there is breathing difficulty, that is very important. And then what is the main feature that bothers our patients? What is it? The examination. I usually examine my patients standing in front of the mirror and asking them to point out what are the areas of concerns. I assess their breathing. I do a Cottle's test. If they say we have difficulty, to make sure that this is not due to collapse of the size of the nose. I feel the nose. It's not only seeing it, you feel it, because if you feel it, you can assess the strength of the cartilages, the ligaments, how long the bones are they symmetrical, what is the state of the skin, are there external scars, look inside the nose. And I mean, one thing, again, I would like to do, but I have not been trained to do it or used to do it, is to pass a fiber optic nasendoscope inside. I use simpler methods, and they're usually sufficient to look inside the nose, assess whether the turbinates are enlarged, especially the inferior turbinate, whether the septum is deviated. Sometimes we use a cone CT scan if we feel that there is a high septal deviation. I've had patients. I don't have access to a studio in my private practice. I used to in the National Health Service. Standard views, as standard as we can get them. I do not use a 3D scan. We'll come to this and to the clinic. Having applied makeup, I mean, it's a bit stupid and silly. So you can do all sorts of things with makeup. I mean, this patient's nose looks a bit collapsed in here. And with makeup, it's just incredible what you can do. So it's a pitfall. We need to be careful. I ask the patients to take the makeup off. And it's easier to ask a woman to take her clothes off rather than to take the makeup off, which is a difficult scenario. Our secretaries tell them, please don't come with makeup. So let us just take an example of somebody who's been photographed. I have already spoken to her, and I'll try to assess her and reason with her. Not the average patient, judging by her age. So is your nose long, madam? Oh, yes, it's long. No, it's not long, because your forehead and your nose and this part of your face are about equal, so it's not long. Oh, yes, I didn't realize that. So it's, is your nose, you have a bump? Yes, you have a bump. That is absolutely true, because ideally the line of the nose should be in here. So it's just a sort of give and take. And is your tip droopy? It may be. No, it isn't, because this angle is a reasonable angle for you. Is the tip of your nose boxy or bulbous? Yes, because we cannot fit it in a triangle, which is equilateral. And is your nose straight? Yes, it is straight. No, it's not straight. We draw the line and see, well, that side is different from that side. The nose tends to move in here. The tip is asymmetric. It's even if the patient is not aware of a feature, we need to bring all these to their attention, because after surgery, they look at their nose with a magnifying glass and find out any imperfection. And if you tell them this was present before surgery. That is a bit defensive. You have to mention this in advance. These views are different. Not infrequently, a patient says, I prefer to be photographed on one side rather than the other. We look at the chin. Oh, there is nothing wrong with my chin. Listen, I think your chin is a little bit weak. It's receding. Your nose looks large. It would look better if your chin is a little bit more enhanced. You can be accused by a patient that you're trying to do more surgery than is necessary, but if you do not mention the chin in a rhinoplasty consultation, your consultation is not complete. So here is a man who came wanting his nose done, and he never thought about his chin. And his nose looks feminine, it's a bit tilted up, it's a bit short. We told him that you need your chin done and your nose lengthened a little bit, you get a better profile. The same story with this lady who came wanting her nose sorted out, and told her, well, if you want your profile to be restored to normal, you not only need the nose done, you need your chin enhanced, you need a little bit of liposuction to add to the enhancement. And patients appreciate this if they see, and all this discussion is while the pictures are on screen with the patient sharing in the discussion. The opposite side is a chin which is a bit prominent, and if the nose is reduced too much, the chin will look even more prominent. So that is the reverse thing. This patient had a big bump and she has a huge chin. So she had a combined procedure of a rhinoplasty plus a mandibular osteotomy carried out by our maxillofacial surgeons. This chap said his nose is long. His nose is not long. It's the projection of the nose, which is the problem in his case. So patients come and tell you, my nose is large, but you have to decipher what they mean by large. Is it the length? Is it the width? Is it the projection? Is it the shape? Is it something relative to the rest of their face? So this journey, talking to the patients, it helps you to understand the patient. Are they pleasant? Are they perfectionist? Are they knowledgeable? Do they need more input? It's a journey into the mind of the individual to try and understand how much insight they have and what their expectations are. One major difficulty we have these days is that patients come with a lot of information that they have downloaded from websites, and it takes ages to try and sort of put things in the correct perspective. This is the difference. There are 2 ways, 10 ways of doing the procedure, and that is consuming. Do we do morphing? It's common now that commercial clinics advertise, we can show you how your nose is going to look after rhinoplasty. I don't use morphing. I think it's a weapon with 2 edges. What I do is, if I get this patient with the projecting nose, I show him an example of somebody similar to him who had the procedure, and I tell him this is real life. This is a patient who's similar to you, who had a similar gender, similar configuration, who had his nose done, and the patient will be happy with this, and we could achieve a comparable thing. It's the same surgeon, the same pictures, to give him an idea rather than just using a computer, push this up, reduce the pressure. You can do anything with a computer. Is it helpful? It can be helpful, but you have to be very careful. Once you show a patient a picture that is morphed, it sticks in their minds. And although you put a lot of disclaimers, they say, but you showed me this and my nose does not look exactly the same. I may be a little bit biased here. So at the end of the consultation, we confirm what is the main feature. Are there other features that can be positively changed? What would be the consequences of change? What would be the additional procedures required? How do we select patients? Patients can ask you all sorts of things and demand changes that sometimes are quite unreasonable. So we have to be careful with these patients. A patient who is vague, cannot express himself or herself, doesn't know exactly, oh yeah, I don't like it, I don't like it. I wanted it smaller. This is not really a good sign. If a patient never looks you in the eye, keeps looking down when talking to you, if the deformity is very small and minimal, and you consider the nose is really, there isn't any big target for me to change. If the patient's expectations are high, I want a perfect nose, doctor. I've really been waiting for this for 10 years and you are the best surgeon and I know you can do it. No, I can't do it. I better avoid this sort of a story. If a patient asks you to change the nose in a way that does not fit the face, it does not fit the aesthetic standards, we want a nose very tilted, a ski slow. If somebody asks you to do a rhinoplasty and you look at it and say, I really don't know how to do it, it's really unethical that you open the nose and try to do something and you feel half the way through that you are out of your depth and you don't know what you're doing. There are some people who say that the male patient can be difficult. There was a paper published with the title, Are Male Rhinoplasty Patients Mad? And the conclusion was, no, it's not mad, but there are stories of plastic surgeons being killed by male rhinoplasty patients who were dissatisfied. I would not operate on a patient under the age of 18 for a pure cosmetic rhinoplasty procedure. I may do a septoplasty, that is fine. And I am careful with women and men who are over 50. They don't heal as well. They have fixed ideas in their mind. I do operate on them, but with a lot of very, very careful assessment and setting of expectations. I offer all my patients second consultation and more than 70% take it. We can do it through Zoom with them if they come from a distance or face-to-face. If I feel uneasy about a patient and I cannot tell him, go away, I don't want to see your face, I refer them for a second opinion. And a number of our patients go for psychological assessment. I send patients a lot of PDFs, about 5. In total, about 150 pages, written in a very simplified way about the nose, its structure, how we do the surgery, how they prepare themselves for surgery. So written information now is a must for informed consent. I tell them about the non-surgical options, and I think my waiting list for rhinoplasty is quite long, but we are required not to operate on a patient within 2 weeks of seeing them. We call it the cooling off period. Now, there is a condition called body dysmorphia. I'm sure you are aware of it. And that is one, a patient magnifies any deformity a great deal in his or her mind. It's not uncommon in rhinoplasty. An incidence of 1 in 10 to 1 in 20 is mentioned. I send my patients for screening, or I ask them to take a screening test, and if the score is high, I send them for psychological opinion. Okay, let us move to the types of rhinoplasty. Of course, plastic surgery started centuries ago when the Indians and the Italians wanted to reconstruct noses. And the plastic means to mold. So molding a nose from the forehead or from the inner arm. So that is what we call reconstructive rhinoplasty. It's not something that I do any longer. There is a post-traumatic rhinoplasty, which is in this country covered by medical insurance. The most common rhinoplasty is cosmetic rhinoplasty. Okay. How are we doing for time? Hello?
We are okay. We are okay.
All right. Okay. Right.
It's okay, sir. Go
Okay.
ahead, please.
Great. So briefly, how do I do my rhinoplasty procedures? Almost always under general anesthesia. Give them a big shot of intravenous antibiotics, local infiltration. I work with 1 or 2 anesthetists who hypotense the patients. We use a vasoconstrictor spray. I book the theater depending on the surgery between 2 to 4 hours. That is for a primary rhinoplasty. The overwhelming majority are done as day case surgery unless I take a rib for grafting. Remove the cast and the stitches in 7 days. We give them an open door. We tell them you could return and see us if you have any concerns. The first 6 months are the first 6 weeks after surgery, where there's still swelling, anxious time for the patients. But they return 6 months and not infrequently a year after rhinoplasty for the final checkup and assessment. How do we do the rhinoplasty? We expose, we work on the septum, the dorsum, the tip, we close, and we may do some additional work if required. So how do we expose the nose structure? Either the closed method or the open method. There are pluses and minuses in each. I think I did my first 1,000 rhinoplasties using the closed method, and then I was persuaded to choose technique. It gives me better visualization and expand the areas that you can tackle in rhinoplasty, but it takes longer. The swelling takes more time to settle down. The close approach, we're cutting inside the nose only, undermining. So we're looking at the nose from 2 directions. So with the closed rhinoplasty, the cuts are inside. With the open, we extend the cut under the columella. Okay. Now, the advantage of this is you have very good visualization. So we expose the structure. The dissection is very important. You have to be as close to the cartilage and the bone as possible. Otherwise, the nose is a bleed, even if the patients have been given local anesthetic and hypotensed. So the exposure takes quite a bit of time to do properly. I usually start with the septum, and a lot of my patients need a bit of septoplasty, or if they do not need septoplasty, I need to take a graft. Septoplasty is a very, very difficult procedure. Fortunately, I've been trained to do it. One of my colleagues who does the rhinoplasties will ask an ENT surgeon to be with him if septoplasty is required. A major form of septoplasty is when you take the whole thing out, correct any deformity, put stitches and replace the septum in place, in vitro septoplasty. Now, this patient had a projecting nose, which was set back, and this looks nice. She wasn't aware that her nose deviates to one side. And without septoplasty, you would not achieve the correction. This is another example of a C-shaped deviation of the partition of the nose. A lot of work is required to straighten the septum and to keep it in place. The septum, like any cartilage, has a memory and tends to go back to where it was. So we do a lot of this work as required. So we're talking about septoplasty now. The lower part of the septum, if you do not correct it, you cannot correct the tip. This patient has a short nose. The septum in her case was exposed. To take a graft and to add the graft to the septum at the anterior inferior end to lengthen the septum to achieve this result. This patient had a rhinoplasty with a droopiness. She wanted the tip projected. Again, she had a graft from the septum. So this procedure, I will have to start by following exposure, by exposing the septum, take an appropriate graft, fix it in here to achieve the projection. Okay, so we talked about the exposure. We talked about the septum and the septoplasty and harvesting the grafts. There are so many variations in our approach. We're just trying to simplify the dorsum of the nose. That is the part that most patients come to see you saying, I have a hump or a bump and I want it removed. And this is an example of a whole bump removed in block. Very few people do this anymore. That is quite a bit of the structure of the nose removed. That's the bone, quite a bit of the bone removed here. That is the septum. These are the cartilages. Now, a procedure like this initially will give you a good result. The patient will be happy. She will return a year later saying, look what's happening here, doctor. The bridge of the nose had collapsed. So if you remove quite a bit of structure of the nose here and do not reconstruct it, the size of the nose collapse, the bones stay out, and you get this deformity, the inverted V deformity. Now, I don't know whether you know this person or not. This is Bella Hadid, father Palestinian, she's American. That is her nose before surgery. That is her nose after surgery. That is quite collapsed here to my mind, and the tip looks pinched. Unfortunately, a lot of the young girls like this look, but I think they later on regret it. And at this juncture of the talk, I would like to just mention that there are now, there is a new description of rhinoplasty. One is reduction, like it's structural, where you remove something, but you either use it or you use a graft to restore the structure of the nose. So not infrequently, I finished a rhinoplasty operation and there is nothing that has been removed. In fact, there is something that has been added. And there is a preservation rhinoplasty. So the structural rhinoplasty is, say we have removed that bump, we need to restore the structure here with the grafts. And these grafts could be from the sides of the nose, or it could be the septum. So this is this was the place where the hump was, and it's been reconstructed. So this is structural rhinoplasty. And the most recent approach to rhinoplasty now is to leave the dorsum well alone, because that is the part that is the most visible. And what you do, you remove bits of the bone here, some internally, and the nose, push the bump towards the face. It sounds simple, but it's complex and it doesn't work in every case, okay? So we've been talking about the dorsum because that is the target in a lot of the rhinoplasty cases. So when we remove the hump, we have this gap. If the nose otherwise is good, we could reconstruct it. If it is broad or it's uneven, we break the bones. That's what we call osteotomies. And there are so many descriptions of osteotomies. And the osteotomies are the cause of bruising after surgery, because if you don't work on if you do not break the bones, you don't get bruising. So when do we break the bones? If the nose is broad, you cannot achieve this look if you do not bring the bones together. When the cartilages are attached to the bones, and you get the structure neater. The tip had a different approach. The other indication for breaking the bones is in post-traumatic rhinoplasty, where the nose is twisted. So this bone is out, this bone is in, it being hit on the side. There are other indications for breaking the bones, the osteotomies. I mentioned a couple. This is the last thing I do in my rhinoplasty cases is the tip. So sometimes you do the tip only. How do we modify the tips? Either by excision, which we don't like because again, it weakens the structure, or by suturing. The beauty about suturing is that it's reversible. You could mold the tip the way you like. If you don't like it, you could take the stitches and do it again, or by grafting. The aim is either to achieve a projection in a droopy tip, to rotate the tip, to define it, to reduce the width, a lot of things. So let us see some examples here. That is a broad tip or a bulbous tip, a diagram. We could remove part, which we call, this procedure we call Kephalic Reduction. I've been removing less and less and less, and I don't do it regularly. Then we can put some stitches. So here is the nostril, here's the cartilage, and there are some stitches to narrow the tip. Here is an example. We've removed a little bit of the cartilage at the top here. We have put some stitches to narrow the tip. We have added a little graft in here to reshape the nose. So a number of maneuvers that you do not use in every patient, you use it according to need. Here is a little graft that is placed here to try and give a better shape in this area. And another reshaping of the tip by suturing. Sometimes the tip is so deformed that you need to have a good support. And that good support could be what we call a columella strut, a piece of cartilage graft that is placed and it's used as a support, as a splint for the cartilages, the weak cartilages, to achieve this look. I'll skip this one. One other thing that we can do is to narrow. This is a procedure that we do in Africans, Middle Eastern individuals, Orientals, Indians, Pakistanis. We have a fairly large Pakistani community in Scotland. So that is one way of reducing the width and the flare of the nostrils. Now, just a summary as far as the tip is concerned, if the tip is covered by thin skin and you change it, the changes show quite readily. If the skin is quite thick in here, that is the best that you can achieve within reason. Okay, so you prepare the patient in advance. So if this lady comes and tell me I want a tip that looks like this, I tell her, sorry, find another surgeon. I may not be as abrupt, but that is what I mentioned. Okay, so I'm just going to finish because there are quite a few other things that one can do, but I'd rather finish and say that rhinoplasty is a challenging operation. Why? There are so many shapes and sizes and configurations of noses. And you need to learn quite a number of techniques to try and produce a result that is satisfactory and meets patients' expectations. Now, with all these shapes, some of them come with deviations, and the deviations come in different shapes too. So that adds another layer of complexity. If you read the books, there are so many techniques described to project the tip, for example, or to remove a hump, or to do an osteotomy. And do you need to learn all about them? You may have to if you want to achieve a good result in every patient. Another thing, one change in rhinoplasty may produce secondary changes. If you're not aware of them, they come back to haunt you. So that is a big nose. That looks like a nice nose, but this patient was left with this problem when seen from the front because the tip was not properly reconstructed. This patient had a small bump, but too much has been removed. She came to see me saying, the tip of my nose is large. Could you do something about it? I told her, no, the problem is not the tip, it's the fact that somebody has removed too much from here. Just to conclude, rhinoplasty is really one of the most difficult procedures in cosmetic surgery. There is a steep learning curve. It's time consuming. You cannot rush a rhinoplasty. Sometimes you think that you finish and you put the last stitch and close, and then you look at the nose, it just does not look right. And you know that if you're not going to do it correctly, the patient will come and ask you loads of questions and ask you for a redo. The patients are demanding and they need careful preoperative assessment, and that is again time consuming. They need extra support after surgery because they are anxious and worried. The surgical complications are not great. The patients are fit and healthy, but the aesthetic complications are not uncommon and they can lead to dissatisfaction. Just to emphasize this, what I've just mentioned, in Edinburgh, we are more than 10 consultant plastic surgeons. There are equal number of ENT and maxillofacial consultants. There are only 2 plastic surgeons who do cosmetic surgery in the private sector. My son is a plastic surgeon. He's been a consultant for 10 years. He saw me doing so many rhinoplasties, and he did it quite a number. And he came one day and he said, Dad, I'm not going to do this operation anymore. All you need 2 or 3 patients returning and say, well, I'm not happy, and you can't understand why they are not happy, I say, well, I better spend my time doing things that I feel comfortable with. So don't do the operation if you are not well trained, if you do not have the time, if you do not want the hassle. I'll leave you with one picture of the Tigris and Mosul, how it looked before 2017. I hope it will be restored. Thank you for listening.
Thanks very much, Dr. Awf, for this informative lecture. السادة الحضور الكرام، نستقبل الأسئلة عن طريق رفع اليد أو raise hand. If you have any question, please raise your hand and we will allow the mic for you.
Silence.
ريثما نستقبل الأسئلة. يبدو أن الأنف له مكانة كبيرة عند العرب. العرب كانت تقول الملاحة في الفم، الحسن في العينين، والجمال في الأنف. وأيضا في الشعر قوم هم الأنف والأذناب غيرهم، ومن يسوي بأنف الناقة الذنب. وهو يستخدم أيضا في المدح والهجاء.
نعم. It is a prominent feature. It's bang in the middle of the face. You cannot hide it. So that is one of the reasons why getting the patients on board and getting them to be happy is not easy. Somebody carried out a study on satisfaction with cosmetic surgery, and guess which procedure came at the bottom? Rhinoplasty. The other procedures were well ahead. And we're talking in general, we're not talking about one. I think rhinoplasty is not an operation that should be carried out by everyone. We are living at a time where subspecialization in everything is becoming the norm. The difficulty in the private sector is that there is some competition, and there are some surgeons who do not know how to say no to patients. Cosmetic surgery has been commercialized to a great extent, and there's so many clinics advertising heavily for rhinoplasty. Cosmetic surgery has been hijacked. So the surgeons are being employed by businessmen and women to do the surgery. They recruit the patients for them through advertising, aggressive advertising, and the surgeons find it difficult to tell a patient no, because if they keep saying no to a patient, they will not be employed by the commercial clinic. It's really not a very nice scene sometimes, cosmetic surgery, but we keep our head down. We try to be as ethical as we can. We get a stream of patients coming back who have had their surgery by surgeons who are not experienced, and they are left with very difficult deformities. Revision rhinoplasty, which I didn't want to cover at this lecture, is more complex than primary rhinoplasty because we're dealing with a structure which has been scarred, it's been changed. We're dealing with tissues that has been removed. It's time consuming and you do not get good results. I tell my patients, if my revision rate with the primary rhinoplasty is 1 in 10, my rate of revision for revision rhinoplasty is 2 in 10. And if it is a third operation, it can be even higher.
Yeah, indeed. We have 2 questions.
Dr. Awf, thank you very, very much for this comprehensive, attractive lecture. I have a question, please. We do a lot of cleft lip surgery as a pediatric surgeon, and they came for us later on after a few years with saddle nose or something which need rhinoplasty. what is the proper time to shift them to plastic surgeon to do rhinoplasty, please?
Left rhinoplasty, I must put my hand on my heart and say my experience with left rhinoplasty is during my training some 35, 40 years ago. So that is, I cannot speak specifically on cleft rhinoplasty. But in general, if you know, with clefts now, a complete cleft, there is a tendency to correct the nasal deformity at the same time. And if you can get it right, a patient may not require rhinoplasty. However, there is a pressure from parents for their kids to have the rhinoplasty or their nose improved before they go to school, before they go to secondary school. And again, personally, when I get a patient, a young individual wanting rhinoplasty, I don't do it before the age of 18 for a number of reasons. I think one is that the individual may not be emotionally and psychologically mature. The expectations may change with time. The structure may not be fully grown. We know in the UK that the associations say do not do a cosmetic rhinoplasty. I think left rhinoplasty may not do cosmetic rhinoplasty before the age of 18.
Thank you very much.
You're welcome. There are the autologous grafts, and that is what we use. We do not use cadaver preserved grafts or any artificial silicone, the like. So the septum is number one as a source. If it is not available, then on how much you need and for what you're going to use it. So if it is something, say, trying to restore of the alar cartilages,